It's amazing that we have been just over 2 years with this since we got the C3 grant, and I am so truly proud of everything that we've accomplished, and you'll hear about a lot of it today. But of course, there's so much more that we need to do. As most of you know, my husband was diagnosed in May of 2022. And I have to say, one of the reasons why I was so keen to start C3 is because I was desperate to find hope. I felt, especially early on in those days, a sense of deep hopelessness every morning when I woke up. And I can tell you from experience that it's very hard to get out of bed when you have no hope. And so our main mission was to grow hope. And we wanted to grow hope for researchers and clinicians, and importantly, patients and caregivers. And probably selfishly, I wanted to grow hope for myself and my husband as well. And so that's partly how we began this journey. And I'm going to use a quote. I'm going to steal a quote that Cynthia used on Friday, which I will use again, I have no doubt. Cynthia is one of our amazing patient partners, and it's from Greta Thunberg. And it is the one thing we need more than hope is action. Once we start to act, hope is everywhere. And I remember when we started this C3 initiative and we were planning this, and I said, I want every single cholangiocarcinoma patient in Canada to have access to molecular testing. And I cannot tell you how many oncologists said, you can't do that. And I remember thinking, well, maybe I can't, that's possible, but for sure I can't if I don't try. And if we as an organization don't try, then we definitely can't. So we may not be able to now, but that is the power of yet. We can't do it yet. That doesn't mean we can't try, and it doesn't mean we can't do it tomorrow. Now, 2 years later, we're almost there. We have molecular testing for almost every province in Canada, supported by C3 in many cases. And our next step is to really find a way that every single one of those patients can use that information and have access to a novel therapy, whether it's a molecularly targeted therapy or an immunotherapy. So we're not there yet. And C3 is a place where hope grows, but C3 is a place of action. And that is why hope grows. And today, if you're here, whether you're a researcher or a trainee or a clinician or a patient or a caregiver, you are bringing that action to life. And this room, I think, is hope. It is all around us. And for that, I am truly grateful. So with that, I will introduce our speakers for the morning. We'll start with Christine Lafontaine. She is our C3 Research Navigator, and she supports patients and caregivers by providing information and guidance while helping them navigate molecular testing, research, clinical trials. She has a master's in molecular biology and experience in scientific research, industry sales, regulatory support, and clinical studies. And she definitely brings empathy, knowledge, and understanding to her role. So thank you, Christine.
Didn't realize you were going to read all that out loud. Right, so we have a little bit of a motley crew here. We've got researchers and our patients and caregivers for the most part. I apologize for those of you who have been here for the last 2 days because there is going to be a little bit of repetition, but I think a lot of the trainees might not really know what it is that we do on the patient side. So I'll go over that as well. So for C3 Hope, we really are trying to connect patients and caregivers with the C3 so that we can provide all of this support and information. So the first thing we needed to figure out was how to connect with these patients. So initially we were thinking physician referrals, peer referrals, and self-referrals. And definitely one of the areas of most growth in the last year or so is the physician referrals. So we really have realized that we need to reach out to physicians, ask to be part of their local rounds so that we can give little 10-minute presentations explaining the value of the C3. And every single time we do that, we just get a little bump from whatever area we have just presented at, that all of those physicians are turning around and making sure that their patients are aware. So in order to kind of access all of the things that we offer, a lot of it is kind of open access, but we really do have a membership process, and that has partially to do with the fact that we are associated with research, and we need to make sure that we are onboarding people in a way that they will be properly informed about the research that we're doing so that they can participate. So when they do want to become a C3 member, this started about in October. Before, it was more of an organic process, but now we have an official onboarding process where people go to our website and they join. There are a few different steps that they need to take through these forms so that we can gather enough information so that when I do have my initial meeting with them, I do have a little bit of a background, as well as taking some baseline research data that Samar will speak to later. And so once they've made contact with us, it gives them access to our monthly newsletter, where we give a lot of information about the events that are coming up, sometimes little bits of education. I remember one time we were talking about a HER2, and HER2 to be tested, you need to have IHC. What is IHC? So I thought, I'll just put a little kind of explanation of what immunohistochemistry is. And then then there's also the C3 Navigator meetings. That's the initial meeting that they have with me. I usually kind of start with a conversation of just what their story is so far, and I explain in a quick nutshell the different aims that C3 has on the research side, as well as all of the different kind of patient caregiver supports that we have. Through the Cholangiocarcinoma Foundation, we've received these really lovely patient care kits, and we add a little bit more information that from the C3. And so it's just a really nice way to welcome them to the community and provide them with some information, as well as a cute little toque and some like mittens and stuff. Then we also run national multidisciplinary rounds. And so this is a physician rounds that we run monthly to allow for the review of different patient cases from across the country. I mean, probably at PMH, they don't really need this because they already have a lot of experts there. But when we look at a country as large as Canada, we really wanted to make sure that every single patient, no matter where they lived, had access to a review by the nation's experts in this field. Then we also provide molecular testing, like Rebecca alluded to, by way of our national patient registry. And then obviously we also provide them access to participate in research, both the C3 initiatives, as well as other clinical trials or anything else that we come across. We want to share that information. So we'll go into more detail about these 3 items first, which I might have already done. So update-wise, when it comes to patient and caregiver supports, we were awarded the grant in 2023. I came on board in July, I believe, and for that entire calendar year, we saw a little over 11 people. And it was really because that was word of mouth. We were still getting the process up and running. The first half of 2024, we saw a little over 25 people. And then in July, at the beginning of July 2024 is when we officially launched our molecular testing programs, and we had 56 info sessions. And then just in the last 3 months, I've done 64, which is really great. So we've had over 250 patient caregivers who have reached out to us, over 150 who have participated in one of those intake info sessions, and we have sent out over 100 patient care kits. Like I said, we've got the monthly patient newsletter. We help provide clinical trial matching support. The reality is there aren't a lot of clinical trials for these patients in Canada, but what we have tried to do is really on a one-by-one basis, reaching out to the individual PIs for these clinical trials to see what we can do and how we can actually connect them. And then I guess I'm also the clinical rounds coordinator. So that ties really closely into the registry, where we collect people's medical records and we add them to this registry so that we can create that real world data that we were talking about before. And then we also do the same type of thing to collect medical records from across the country so that we collate them into the rounds presentations. And then one of the other things that kind of came up, that was all kind of the plan. And one of the things that came up as we were speaking to all these people, was that need to help people connect and create local communities. And so it's kind of become my little side project to try and really help local people meet up. And even though we are involved in the virtual support groups, it is really important that people meet each other in person. And that's why this meeting has been so impactful. And so that is one of the things that we are looking to help do moving forward, because the more agency that patients and caregivers feel that they have at a grassroots level can only help our research initiatives grow and our network grow. So as I said, we're intentionally building that cholangiocarcinoma community in Canada. We have a Facebook group. We try to help facilitate local meetups. I run some C3 chats, which are not quite webinars. It's just we kind of choose a topic and have discussions around that topic. So for instance, growing community, or like accessing care outside of your local hospital. And then we also are members of the support groups and advocacy groups that the Cholangiocarcinoma Foundation of the States helps organize. So the other part that I've also spoken to is the patient registry and funding for molecular testing. So our patient registry, I don't have it in the slide deck, but we have partnered with a couple of different organizations, including the Terry Fox Marathon of Hope, to collect information from across Canada, and so that patients have access to their own health data. And so we have partnered with a company called Citizen Health. They have already partnered with the Cholangiocarcinoma Foundation in the States. And so that's where the International Patient Registry is run out of. And we are trying to help bring that into Canada so that patients have this really beautiful platform so that they can see all their data, all their information really clearly, and share it with whomever they need to share it with. And then this also is the avenue that patients can choose to share their data for real-world evidence research. And then, as you've seen this slide a few times in different iterations, but the importance of finding out your mutations and the associated molecular therapies. We are involved in Ontario and the rest of Canada for this molecular testing. And since launching in July 2024, so it's about 9 months ago, we've done about 100 tests, half of which in Ontario and the other half in the rest of Canada. And our next steps are to continue that physician outreach and education so that all the physicians know that this is something that is available now. And the plan is to kind of bring this data, like knowing what fusions, what mutations people have, and we can take that information to help bring more clinical trials into Canada, share this information with drug companies to show that there is an ability to find these mutations and an appetite for providing these drugs in Canada. And then the other idea is that this can help drive the data that the CDA requires or the Health Canada requires for their drug reviews. And then for national multidisciplinary rounds, we have grown our professional network as well. So now we have over 150 medical experts from across the country. And one of the main things, like I mentioned, was the rounds. We've had 10 sessions to date, and we average about 20 to 30 attendees per session, and we've presented 27 patient cases, where we then provide some summary reports to physicians. And then we also often will do a short educational session at the very beginning of the rounds so that we are helping educate the physicians across the country, as well as helping patients get those it's kind of like a second opinion, or just assurance of like what to do next in their particular case. That's just a screenshot of one of the rounds. And then again, the last thing, but definitely not the least, is providing these people an opportunity to participate in research. So that's through either clinical trial matching or access to, or the opportunity to participate in the C3 research projects. Such as the real world evidence collection through the registry, and the psychosocial research that Samar is doing. So I can pass this over to Samar now, and she will tell you a little bit more about that. Oh, sure. Yeah, and I can take any questions.
Oh, if anyone has any questions.
Not so much a question, I just wanted to add that, so the registry is, I think, a really important part of what we do, because we need that real world data around what mutations patients have, around whether anyone's getting access to molecular therapies, clinical trials, all of that information, and then we can use that to help support applications for new drugs through the payments on agency and that kind of thing. So currently that's like we got to the point where the registry is now kind of operational. The one piece of it that I really wanted is that patients would have access to their data once they join the registry, and that's what the International Cholangiocarcinoma Registry does. And so that's the piece of it that I think we need to still do. We haven't done yet. And that's we have a pilot project with Citizen, that's the company that hosts the International Cholangiocarcinoma Registry. But in an ideal world, by the end of this grant, we would have patients sign up. We would procure your data on your behalf, as they do in the US. We would take all your data and collate it into essentially a virtual but private chart that you as a patient could share with any provider you choose. And you can share with the C3 for research, you can share with the International Cholangiocarcinoma Registry for world research. And so we're not quite there yet, but we're making progress.
Yes, I just try to talk over that, as much as OICR. I really like this, and I think as it takes off, I was wondering whether there's any, and we have all these patients here and patient advocates. It seems to me that this C3 consortium could be a model for how we can handle other rare cancers in Canada, not just cholangiocarcinoma. Creating a patient network like this for care, for molecular testing, for sarcomas and other rare cancers, brain cancer. And I think that this is, I'm a big thinker, so I think that as you show success with this, I think there's a huge opportunity to transplant this model to other types of cancers. And then so you could imagine, you know, a Canadian sarcoma and a collaborative, you know, consortium, a brain cancer, a sarcoma, and other rare cancer. Hereditary cancer and stuff like that. So I congratulate you on doing this, because I think the next step should be advocating for what's transplant more of those things.
And I think the great power of this is, like, we think of ourselves really as like a hub and an avenue for connecting. So we really are lucky to be able to reach into the physician community, reach into the patient and caregiver community, as well as researchers and pharma, and really be able to help people connect. And that is where the power comes from. So thank you.
That's again. Please, Hi, I'm Neil Marr. I'm served as a research advocate, so be gentle, I'm not a medical person. But I'm just wondering what you foresee as the next steps in terms of making oncologists across Canada aware of things like access to molecular testing and the registry, and is there a role for people like myself to play in that?
I know, yeah. I mean, Leonard and Christine have done a fair number of sessions at each hospital cancer center will have its own multidisciplinary rounds, usually for GI. So it would include everything from colon cancer to gastric cancer to esophageal cancer. And so they've been really proactive at trying to identify those individuals and then make a presentation at their rounds. So go to them and tell them about what we have. I think the molecular testing has been good, because generally physicians really want that for their patients. And so they're willing to kind of join C3 and maybe kind of become part of it because they have access to that testing for their patients. But Obviously, we have more work to do because there are still patients who tell us that they've never heard of C3, their doctor hasn't heard of C3. So we know that we're not everywhere yet, but I think that's what we continue to do. So in terms of what patients can do, if you know about C3 and your doctor doesn't, give them a pamphlet, give them the website, tell them about it, ask them to connect with us. We would love to hear from everyone who treats cholangiocarcinoma in this country.
Hi, I'm a patient. I'm a part of the National C3 Patient Registry, which I'm very grateful. And now the next step up would be joining Citizen Health to make it more, even more national. The only thing that holds me back is everything that's going on in the world these days. And I believe that the Citizens Health is run through the states and with the misuse of artificial intelligence and all these things. It's just the security of my own personal record and what it's going to be used for. And that's what's sort of holding me back a little bit from going that next step. So I don't know how others feel, but I feel very secure with C3. But maybe I'm getting closer to maybe joining Citizens Health too, but let's see.
Yeah, it's actually it's an excellent point. And so anyone who's joined C3, the registry now, your data is held in Canada. So no, even though it's held within the EPIC electronic medical record, which is owned by the US, it's held within Canada. And we obviously when the election happened and there was sort of a lot of fear, we actually checked all of this with our hospital to make sure, not just for C3 patients, but for all patients, how safe is our data. And I think it's pretty safe, but you raise a really good point. I hadn't actually thought about it too much, but like, I think we'll bring that back. And because you're right, once we partner with the International Cholangiocarcinoma Registry, that data will be going to the US and we will lose some control over that data. So something to think about. Thank you for raising it. Yeah, do you want to? Yeah.
So Melinda,
Definitely a concern.
just introduce yourself, Melinda.
I'll
Introduce yourself.
Oh, sorry. I'm Melinda Bikini. I'm the Chief Patient Officer at the Cholangiocarcinoma Foundation and also a 15-year survivor of stage 4.
Yay!
Very closely with Citizen Health, and we are trying to get this registry, populated with information so that the information can be provided to researchers to advance the research. But this is a concern for many patients. So we have gone way out of our way to make sure that there is safety, to the point of if even something happens to Citizen Health, the Cholangiocarcinoma Foundation then would keep all the data. We would own the data, so your data would not be going anywhere else. And you consent when you sign on to share your data with CCF or for research purposes. You don't have to, you can. But the really other good thing about it is we partnered with Citizen because they went out of their way to make it safe for all patients. Electronically or however technology works, I have no idea, but we do feel confident in that and they've taken the measures to prove that to us. But also as a patient, your data gets sold out the back door in so many different ways.
Yeah.
And we really wanted to make it not happen that way, that you enter through the front door, you consent, and it doesn't go anywhere without your permission. And the good thing about it is when industry partners come in and use that data, patients will get a reward for it. You get paid for them accessing your data, and that doesn't happen in many ways. Most of the time that data is sold without you knowing about it, but we made sure that when we partnered with them, that as patients, you would get part of that profit that industry pays to Citizens. So they're not just taking it as a profit, but they're sharing it back to the patients who participate in it. We can probably talk more about it. It will be at the conference next week, but I'm happy to if you ever need it, to gather more information. But I just want you to know that we've gone out of our way to make sure that the data is safe and that it is a good platform for patients to participate.
That's very reassuring. Thanks, Melinda. Yeah, so there's just one question online about the map for the medical experts. Is it sort of an interactive map telling you where the physicians are? It's not, but it's a great idea, and we'll get a smart trainee to do that for sure. All right, so I will introduce Samar now for the next session or next segment of this session. Dr. Attieh Samar, she works with Professor Carmen Loisel, and they lead the hope aspect of this study. Dr. Attieh examines how hope and loneliness change over time for individuals involved in the C3 initiative and to identify strengths and gaps in C3's contributions, guiding advocacy, future research, and improve patient support. Dr. Attieh.
Thank you, Dr. Auer. Hello, everyone. I'm Samar. I joined this incredible team of C3 more than a year ago when I was finishing my PhD. And then in September, I switched to a postdoctoral role, to a postdoctoral fellow role. For patients and caregivers who joined us today, I'm the one who annoys you with DocuSign, sign consent, who follows up with you to complete your surveys. I work on the HOPE study, under the HOPE study lead, Dr. Carmen Loisel. I will present today a brief overview on the psychosocial impact of being diagnosed with a rare cancer, the evidence from the literature, why we are conducting this HOPE study, results so far, and next steps. I think by now we are all familiar with the challenges facing patients and their families diagnosed with a rare cancer, but there is enough evidence in the literature about the limited access of specialists, the molecular testing. I think we all heard over the last 2 days the difficulty in accessing clinical trials, the geographical barriers, the high treatment cost, even if it's available in another province, the targeted therapy, out-of-pocket expenses. So all of that has a huge, significant psychosocial impact on patients and their families. And it's well written in the literature, documented in the literature. We have patients having a rare cancer report often a high levels of distress, social isolation, high anxiety. And compared to more prevalent cancer, patients diagnosed with a rare cancer have usually a lower quality of life. When it comes to biliary tract cancer, the evidence is more limited because of the lower sample size, but we have enough evidence to say that they report high symptom burden affecting their daily life, work productivity, and physical and mental health, with a significant psychosocial unmet needs and financial concerns. For that, there is an urgent need for evidence-based intervention to guide us to best support people lived with a rare cancer or BTC. Because of the high impact of a biliary tract cancer on health outcomes among patients, we need to explore the key concepts that affect and that we know that they affect health-related outcomes, such as hope and loneliness. So literature documents that hope, being hopeful, is significantly related with lower depression, with lower distress and symptom burden, and higher probability of survival and even better coping. On the other hand, social isolation and loneliness is associated with cancer progression, higher depression, higher anxiety, and lower physical quality of life and survival. So given the importance of these two concepts, there is still knowledge gaps in terms of hope and loneliness among patients diagnosed with cholangiocarcinoma and how to best support them. So that's why we created this HOPE study. The HOPE study is co-designed with Dr. Auer, with patient's partner, with Dr. Loisel, who is an expert in psychosocial oncology. We co-designed the study to measure hope and loneliness over time for C3 members. And we wanted to measure quantitatively hope and loneliness, but we didn't want just scores. We didn't want just numbers. We wanted to ask patients about their perceptions about hope, their experience, to hear more about their experience, and patients along also with their caregivers. Because hope is can be different to each one of us. It can be hope for a cure. It can be hope for timely access to services and support. It can be hope for having your drug covered, the cost of drug covered. So the qualitative part is very important in our study to hear more about your experience. So potentially with the quantitative and qualitative sections of the study, we will assess the strength of our program, what we are offering, and the gaps and how we can improve C3 initiatives. A minimum of 30 patients and 30 caregivers are needed to conduct this study, and that across the 3 time points that I will explain shortly. It's a mixed method because we are combining quantitative and qualitative data. It's across Canada, of course, and based on repeated measures of hope and loneliness. We use 2 validated questionnaires for hope and loneliness that are well validated in the cancer population. And we added few questions about medical work and life changes because with time, patients experience changes in their medical condition and in their work situation or physical or emotional health. So we wanted to account for these when we measure hope and loneliness quantitatively. And we also added some measures about preference for cancer information. Are you an intense seeker for cancer information, or you tend to avoid having information about rare cancer, or you just need information that add to what you know already? So as Christine explained, individuals with BTC will connect with Cholangio.ca with our online platform, even by self-referral or by physician referral or word of mouth refers by patients or advocates. And that's when they will complete the measures at baseline. So we will ask them to complete sociodemographic information, medical history information, hope and loneliness scales. And then they will book a session with Christine with the Research Navigator. And for our sample of patients, it was less than a month between completing their baseline information and meeting Christine. After the info session, I will send you the informed consent form. I will follow up with you to have, if you have any questions, go over it if needed, and explain to you that you are signing on the consent form to use the baseline data that you already completed for research, for the real world database, and for the HOPE study. And at the end of the consent form, there is an option if you would like to participate also in the qualitative part in the focus group. After 2 to 3 weeks of the info session, we wanted also to measure hope and loneliness again to see the impact of the first info session. And then we added a 3rd time point, which is T2 here, which is very important to note because we wanted to give patients and caregivers the time to interact with C3 initiatives, maybe to have molecular testing, joining advocacy group, joining the supportive group, reaching out to Christine, having more information. So the info session is giving you all the resources that we are offering, but at T2, we wanted also to see the interaction with all what we offer. So far, I think we have more than 67. We are over 70 now, but when we did this presentation, it was around 67 signed consent forms. So patients and caregivers are very interested in participating in research. They are very eager to give their data to research, to participate in the HOPE study. And the results that I will share with you are based on the 48 participants, 48 patients. We didn't analyze the data for caregivers yet because of the low sample size so far. For the 48 participants that we have, the mean age was 6 years old. They are distributed across the province. The highest percentage was in Ontario with 18 participants and 11 in British Columbia. We have a pretty balanced sample between males and females, 52% to 47% of female. The majority were married and having kids. Caucasian, 85%, and 35% were retired, not due to health problem, but 14% were on disability or sick leave. As for the medical history, which is interesting here to note, is that 37%, that's 18 out of 48, did not know the type of BTC that they had. We have 14 out of 48 having intrahepatic cancer, and extrahepatic, we have 14.6%. 76% of our participants were diagnosed just last year. 25% had surgery for tumor removal, and 66% were under active therapy, chemotherapy, immuno, or a combination of both. We adapted 4 questions from the Cholangiocarcinoma Foundation intake form. We asked participants if they were provided with treatment options and if they understood the treatment options they were provided with. The majority said yes, agreed or strongly agreed that they were provided with treatment option, and 85% understood the treatment options that they were given to by their medical team. However, when we ask about more advanced information, you know, the percentage, the highest percentage flipped to the strongly disagree and disagree when we asked them if they were provided with information on biomarker testing. We have around 58% strongly disagreeing, or being neutral to this. And when we asked if they were provided with information on clinical trials, you know, 71% almost replied that they were strongly disagree about the clinical trial. I think we heard from participants yesterday, from patients and caregivers about that as well. The hope score. Overall, patients reported high level of hope. If you can see the range for the hope scale, it comes from 12 to 48. The higher scores are indication of higher hope. They were hopeful. We started with a 40, a mean of 40 at baseline. This rate, or this score, decreased a little bit after the info session, with a significant decrease when we compared T1 to T0, but we cannot forget that we started with high scores. On the opposite side, loneliness. Overall, participants also reported low level of loneliness. They were not as lonely. If you can see that scale here, we are on the lower end of the scale, so low loneliness levels. Also, after the info session at T1, we noticed a significant higher post-information session loneliness scores. Now, I mentioned 3 questions that we asked participants if they have a change in their medical condition, if they quit their work, or if they had a physical impact based on the symptoms they had. We accounted for these 3 time covariant elements, and they did not affect the hope or loneliness change over time. So we wanted to dig deeper into the analysis, and we saw that we have a pretty balanced gender sample. And we know from the literature that women tend to express more their emotion or ask more for help or support. So we wanted to stratify the sample, the hope and loneliness data, by sex and gender, and we got interesting results. So for the woman group, we did not notice any significant change in their hope or loneliness level after the info session. However, when we analyzed the data for men, we had an increase, a significant decrease in hope and increase in loneliness. So what does this tell us? Are we helping women to sustain their hope level and prevent deterioration of their hope or increase in their loneliness? But more tailored support is needed for men. It's very interesting to explore this in our next focus group that we are conducting. So we will conduct the focus group with patients and caregivers. We want to hear from both of them. We need to explore the emotional impact of a diagnosis, their unmet need, what we need to do as a tailored support for men and women, the influence of hope, what are the elements that challenges to maintain their hope, and what contributes to high hopes, and their perceived priorities in research and advocacy. So the study is still ongoing. The findings so far are informative, but we need to finalize the data collection and data analysis for T2 to have more conclusive patterns. And it's very essential to conduct these focus group to learn more about what is missing, what patients and caregivers think, to have a complementary understanding of our findings, to eventually enhance our support and development of more supportive and tailored interventions. Thank you so much for listening, and I'm ready for any questions.
Being a surgeon, a liver surgeon, and thank you for the presentation. It's very interesting data. As a surgeon, I can I see that the hope factor is changes tremendously when I sit in an office and I tell a patient that he has surgically resectable disease or another one that cannot intervene surgery, and when a patient comes back with a recurrent cholangiocarcinoma, then the hope you can get from systemic treatment, or a patient that has refractory disease to first-line treatment, the hope you can expect is also quite different. So my advice is to make sure you have balanced number or sufficient numbers of patients in those categories. Because the whole factor is going to be very different whether you're starting on this journey and you have a resectable cancer,
Yes.
or you're at the end stage of that journey where the option are scarce. And
Yes, I agree with you. It's that for the 48 participants they have been diagnosed just last year, but we have other participants who joined the CIS3 way before. We have around 200. So we had some discussions about comparing the data with patients who have been diagnosed and have more experience and more knowledge about the treatments and targeted therapies that are available or being engaged in a new clinical trial. So we have these discussions of comparing our data to other patients.
I'll go with running it. Just a quick clarification. The caregivers in 19, did they overlap with the patients at the same time, or they were completely separate?
They overlap with the patients.
Okay,
Yes.
so the magic functionality variable is, I guess you have to take a look at the interaction between the caregivers and the patients.
That's true. We aim to compare, and we were interested in collecting also data. When we designed the study, it was only for patients, but we had some feedback from caregivers that they wanted to be implicated also. We have enough evidence from the literature that sometimes caregivers have other preference for cancer information. They tend to be sometimes more active in searching for information about cancer. So it will be very interesting to compare also patients and caregivers as well.
I'm very interested to see if you deployed this survey to this group of participants after this weekend. I think it's a good idea.
I don't know if we need an amendment in ethics or they will agree with that. Thank you so much.
Thank you very much. I think the results really, they're a little bit unexpected. I think we assumed that, the meeting with the research navigator, seeing what's available would increase levels of hope and decrease loneliness. But this is why we need research, right? So now we need to dig a little deeper. What's actually going on? Is there things that we're doing that are not helpful? Are there things that we're not doing that we need to be doing? is something else going on? So I really thank you for taking such a rigorous and scientific approach to hope, because I think what I thought was going to be an obvious thing is not. And so we need to know why. All right. So another just aspect of, again, what we have done with C3 has to do with advocacy. And of course, we say in C3 research is care. And what we mean when we say that is that every patient should be offered an opportunity to participate in research. The research itself may not be standard of care, but the opportunity to engage in research should be standard of care. And so part of this is advocacy to really make our political stakeholders, as well as the public, understand that research is not something that happens in a lab, in a university, in a far off place. This is something that impacts us every day as patients. Clinical trials are part of the care paradigm that we face. So we have partnered with CCHC, and we have monthly advocacy meetings. And really kind of focus on what are the main issues that we want to address. Pemigatinib is a drug that has been approved in most other Western countries, including in Europe and in the US, approved for funding. But pemigatinib is for patients who have FGF2 translocations. It is quite effective. The issue in Canada, it was Health Canada approved, I think 3 years ago now, almost 900 days ago, but it was declined for funding. So it basically meant that it's available to Canadians, but not funded by provincial, not recommended for funding by provinces, except for Quebec, because they have a different process. So even just kind of understanding what that process is, yay, Quebec. What is that process and how do you influence that process? And when we started C3 was kind of right at the beginning of this, finding out that there wasn't a foundation. So I think, again, in collaboration with CCHC, with all of the patients here, there was a very significant advocacy effort, including letter writing to health ministers, including Minister Holland, media outlets, and many patients spoke up about this. And we partnered as well with Insight, who's the company that makes pemigatinib, and they were very supportive of, obviously, in this initiative. But I think this is really the power of an organization like this to have voices from researchers, from clinicians, from patients, from caregivers. And I'm very happy to say that on Thursday, there was a draft positive recommendation from the Canadian Drug Agency that pemigatinib will be recommended for funding. We have several other drugs that are coming down the pipeline. We have ivosidenib for IDH1 mutant, and we have zanidatamab for HER2 overexpressing cholangiocarcinomas, both of whom have positive data and have FDA approvals. And so we need to learn from the process, what went right, what went wrong, and we need to be ready to support these applications for both Health Canada approval and funding in this country. One of the things that was a problem with the whole pemigatinib process was around having insufficient real-world evidence from Canadian patients around molecular mutations. So they asked, do you have any data on FGF2 translocation, patients with FGF2 translocations in their tumors in Canada? And the answer was, we don't, but we do now because of you, because of C3, because the patients have signed up for the registry, because they're getting molecular testing. So hopefully this is the beginning of being able to say, yeah, we do, and here it is, and you need to fund this drug. So I think that's a very powerful thing. And also just, you'll see on the bottom, some of the lighted up green for World Cholangiocarcinoma Day. So again, in partnership with the CHCC, we've had a number of cities with meetups and lighting up. Go forward. Sorry. Yes. So a number of different cities across Canada, Little Stars, I think, are meetups, and having something lit up green. And there's some pretty amazing stories. So Cynthia in Winnipeg, how many people did you guys have? 71 people, including members of parliament. So what? Next slide. Yeah, Leonard should have done this part, sorry. These are some beautiful pictures of all the different places with lighted up green. I think it's just the power of the people to bring the message and bring awareness to cholangiocarcinoma. This was our little Ottawa group.
It was cold.
It was cold. We're buying more green hats for next year. But I was very proud to have my family there and so many other patient supports and the C3 team. So thank you. So with that, I'm going to introduce our patient partner.